Assalamu alaikum. I am Dr. Junaid Jahangir Abbasi and I am Senior Registrar in Pediatrics at Rawalpindi Medical University. Today I am going to tell you about the different Viva questions that can be asked in the examination of the cranial nerves. First of all, the first nerve is olfactory cranial nerve. In this nerve, the examiner may ask you, what is anosmia? Anosmia is loss of sense of smell. What are its causes? It can be caused by head injury, it can be caused by tumor of anterior cranial fossa, and it can be caused by tuberculous meningitis. Then he may ask you, what is parosmia? Parosmia is perversion of sense of smell. If you give a patient a pleasant smell and he says that it is too bad smell, that is perversion. Or if you give patient a bad smell like a smell of rotten egg and he says what a good smell it is, this is perversion. So parosmia is psychogenic in origin. Then the examiner may ask you, in which conditions the patient have hallucinations of smell. The hallucinations of smell are present in temporal lobe epilepsy. The next is the second cranial nerve, which is the optic nerve. In second cranial nerve, the examiner may ask you, what is hemianopia? What is quadranopia? Hemianopia means loss of vision affecting one half of the visual field. And quadranopia means loss of one quadrant of visual field. The examiner may ask you, what is optic atrophy? In optic atrophy, the optic disc becomes pale. He may ask you, what is papilledema and what are the changes seen in optic disc during papilledema? So papilledema means increased intracranial pressure, and the signs of papilledema are the physiological cup is obliterated. There is the margins of the disc, they are blurred, dot hemorrhages may be present, color of the disc is pink and hyperemic, and the veins are congested. Then the examiner may ask you about the different causes of raised intracranial pressure. The intracranial pressure is raised in malignant hypertension. The intracranial pressure is raised in type 2 respiratory failure, in which there is increased partial pressure of carbon dioxide. So whenever there is increased intracranial pressure, there will be papilledema. Then examiner will ask you, what is papillitis? Papillitis is inflammation of the optic disc. Then the examiner may ask you about the different questions regarding the pupil. What is light reflex? What is direct light reflex? What is consensual light reflex? What are the causes of ptosis? Remember that ptosis can be present in third nerve palsy, in Horner syndrome, and in myasthenia gravis. Then the examiner may ask you about the different causes of dilated pupil. Dilated pupil, you have to answer like this, that dilated pupil can be present bilaterally or unilaterally. Bilaterally due to anxiety, and unilateral due to mediastinal drops and third nerve palsy. Similarly, he can ask you about the causes of constricted pupil. You have to answer in a similar manner. There are bilateral causes and there are unilateral causes. Bilateral pupillary constriction is seen in old age and in pontine lesion. The unilateral pupillary constriction can be caused by meiotic eye drops like pilocarpine and in Horner syndrome. Then the examiner may ask you about questions regarding the fifth nerve. What is the name of fifth nerve? It is trigeminal nerve. Is it a motor or sensory? Or it is both? The answer is, it is both motor and sensory. What are the sensory components? What are the motor components? The sensory components include the corneal reflex and the checking of sensations in the trigeminal, maxillary and the mandibular division of the trigeminal nerve, like this. The motor components include the contraction of the masseter and the pterygoid and the jaw jerk. He may ask you, do we have normally jaw jerk present? No, we don't have normally jaw jerk present. In which condition the jaw jerk is present? It is present in pseudobulbar palsy. About facial nerve, he may ask you about the difference in upper motor neuron lesion and lower motor neuron lesion. Remember that in upper motor neuron lesion, since the upper half of the face is supplied by the nuclei of the facial nerve from both cerebral cortex, therefore in facial nerve lesion, which is due to upper motor neuron lesion, the upper part of the face is less severely affected. If there is facial nerve lesion of the right side, the mouth will be diverted towards the left side if there is upper motor neuron lesion. And in facial nerve lesion due to lower motor neuron lesion, ipsilateral half of the face is affected. If right side of the facial nerve, if right facial nerve is damaged, then the face will be diverted towards the left side if there is upper motor neuron lesion. The lower motor neuron lesion is also called as Bell's palsy. Now, in facial nerve lesion, whether the taste is involved, whether hyperacusis is involved, whether genicular ganglion is involved, whether 7th and 8th nerve both are involved, or the other any cranial nerve involvement will depend upon the site of lesion. If the lesion is after the nerve exits from the skull, there will be weakness of only facial muscles. If the lesion is in the facial canal, then the taste will also be affected. If the lesion is between the nerve to the stapedius and internal auditory meatus, there will be hyperacusis on the affected site. If the genicular ganglion is involved along with vesicles in the external auditory meatus, it is called Ramsay-Hunt syndrome. If the lesion is in the internal auditory meatus along with 7th nerve, the 8th cranial nerve is also involved. If the lesion is in the cerebropontine angle, then 5th, 6th, 7th and 8th, all 4 nerves are involved. And in pontine lesion, if the lesion is in the pons along with the facial nerve, 6th nerve is also paralyzed. And there is upper motor neuron hemiplegia on the opposite side. Then the examiner may ask you about interpretation of 8th cranial nerve, which is vestibulocochlear nerve. Mostly cochlear part is asked in the examination. What is Rennie's test? What is Weber's test? What does Rennie signifies? What does Weber signifies? Remember that whenever we get news of something positive, like HIV is positive, like HCV is positive, then the positive thing is considered to be dangerous. But in Rennie's, the negative thing is considered to be dangerous. We all have a positive Rennie's test. So if the Rennie's test of somebody is negative, that is a serious matter. Rennie's negative means there is conductive hearing loss. Now, what is Weber? Weber is normally centralized towards both sides. If Weber is lateralized towards one side, then it can differentiate between sensorineural hearing loss and conductive hearing loss. Remember, if the Weber is lateralized towards the better side, this is sensorineural hearing loss. And if the Weber is lateralized towards the disease side, this is conductive hearing loss. Then the examiner may ask you about the 9th and 10th cranial nerve. What is R test? What is puff test? What is cuff test? How is the speech in 9th and 10th nerve damage? The speech has a nasal twang. The cough is like the bovine. What will happen when you offer drink to the patient? There will be regurgitation of food from the nose. How will be the speech? The speech may have hoarseness of voice. And the examiner may ask you, is there any element of dysphagia in 9th and 10th cranial nerve? Yes, dysphagia can be present in damage to the 9th and 10th cranial nerve. Then the examiner may ask you, what is the name of 11th cranial nerve? The name of 11th cranial nerve is accessory cranial nerve. Which muscles are tested in 11th cranial nerve? Trapezius and the sternocleidomastoid are tested in 11th cranial nerve. Then he may ask you about questions regarding 12th cranial nerve. What happens when both sides of the tongue are paralyzed? In bilateral tongue paralysis, remember there is dysarthria. I repeat, in bilateral tongue paralysis, there is dysarthria. If there is bilateral lower motor neuron lesion of the tongue, there is fasciculations and wasting. If there is unilateral lower motor neuron lesion of the tongue, wasting and fasciculations are present on the affected side only. Remember, there is a mnemonic, जुबान साथ देती है, uvula साथ नहीं देता. Means that the tongue will be deviated towards that side where there is a lesion, and the uvula will be deviated towards the opposite side of the lesion. जुबान साथ देती है, uvula साथ नहीं देता. I hope this video will help you in your examination. All the best. Thank you so much.